As you may know, following the upcoming December 8th episode of Endoscopy Talks, the series will be coming to a close after having delivered live broadcasts of 40 webinars starting back in June of 2020. This has been the cooperative effort of moderators Dr. Christopher Chamness and David Tweet, the show's producer, Mr. Jeff Dotson, and the many talented speakers who have given generously of their time. A huge shout out and sincere thank you goes to each and every one of you. We at CSU Vet CE would also sincerely like to thank Karl Storrs Veterinary Endoscopy for their support of the Endoscopy Talks CE series. The recordings of these webinars will remain on our website at www.csuvetse.com. Speaking of which, we're excited to introduce to you an all-new website experience coming in the spring of 2022. In it, you'll find an interactive user experience and an expanded CSU Vet CE community page that will introduce an all-new podcast series, monthly webinars and blogs, and a growing online course catalog. So be sure to stay in touch with us at www.csuvetse.com and check out our many in-person CE courses in the meantime. Now, please enjoy this episode of Endoscopy Talks.
Thank you, Ross, and hello, everybody. Welcome to another episode of Endoscopy Talks. I'm Christopher Chamness with Karl Storrs, and I'd like to thank you all once again for joining us on behalf of Colorado State University's Translational Medicine Institute. Today, we are joined by Professor Steve Divers at the University of Georgia. Steve graduated from the Royal Veterinary College in London in 1994. He obtained his certificate and diploma in zoological medicine from the Royal College of Veterinary Surgeons. He's a diplomat of both the American and European colleges of zoological medicine and has lectured at over 80 national and international conferences across the globe and provided practical training and workshops in more than a dozen countries. Today, Steve will be speaking to us about the applications of endoscopy in reptiles. So without further ado, Steve, take it away.
Thank you, Christopher, and thank you, Colorado and Karl Storrs for putting on this wonderful webinar series. This is my second time, so I hope I didn't suck too much the first time. This lecture is going to be on the benefits of endoscopy in reptiles, and you can see there's a QR code here at the bottom of the screen, and if you use your iPhone and the IT magic works as it should, that will take you to a folder and you can actually download the PowerPoint color PDF file for this lecture if you want to see some of the pictures and images again. So I'm going to start by just really just indicating that anesthesia is going to be an essential component before we can perform endoscopy in our reptiles. The reason I say that is because there are situations in research where we may elect not to use general anesthesia, but for clinical cases, anesthesia is going to be essential. So any contraindication for general anesthesia is going to prevent clinical endoscopy. And you really have to have confidence in your anesthetist because you're going to be focused on the endoscopic procedure. And indeed, you might not even be looking at the patient. You're going to be looking at that monitor. For most of our reptiles that present sick, fasting is not usually an issue. They probably haven't eaten potentially for weeks, if not months. But if they are still eating, then typically we fast them for one feeding cycle, which could be anything from 2 to 14 days or more, depending on the species. I also like to encourage reptiles to urinate. You can see one of my residents here is doing some digital cloacal stimulation to attempt to tempt this tortoise to urinate. The chelonians really specifically have very large bladders, and if you can encourage them to urinate by either bathing them or doing some digital cloacal stimulation, that may help to empty that bladder and prevent that as a hindrance. Rodney, my resident, is enjoying that more than I would actually hope. But anyway, moving on, for anesthesia, typically we're pre-medicating many times with midazolam and hydromorphone. We're using either propofol or afaxolone intravenously. There are some intramuscular combinations. I'm going through this quickly because I want to focus on the endoscopy. But the point is we need to maintain a fairly high standard of anesthesia if we're going to be performing these endoscopic procedures, particularly those involving the coelom, because most reptiles do not have any kind of functional divide, certainly not a functional diaphragm, and therefore insufflation pressures will affect ventilation. So attention to anesthesia is going to be critical. So let's start with the lizards and work our way through. So there's a couple of different options and approaches for performing endoscopy, celioscopy in lizards. For the round-bodied or the laterally compressed, so chameleons, the iguanids, we can perform a lateral approach. And here you can see that our entry point, although it's marked with an X and a blue circle, you can actually place and enter your scope in this complete area here, as long as you avoid the lateral processes of the vertebra up here, and we avoid the last rib, and we avoid those pelvic veins that come down either side to form that ventral abdominal vein. There is no, or we try and avoid any midline approaches in most of our reptiles, certainly in the lizards, because of that abdominal vein. In a big lizard, you could even go intercostal if you wanted to be further cranial, but this is our general sort of entry point in this location. This is great for seeing pretty much most of the organ systems. However, it's obviously much more difficult or impossible to see those deeper, most dependent sides. So in this side, and this left approach, we can see the left kidney, the left lobe of the liver, we can see the stomach, we can see the spleen. We would have trouble seeing the right-sided organs. For those lizards that may be more ventrodorsally compressed, or in round-bodied lizards, you could do this approach as well. We have a more ventral approach. You can either go either side of the abdominal vein, or you can go behind the umbilicus in the midline, which the pelvic veins tend to anastomose and form this abdominal vein at the level of the umbilicus or just around the level of the umbilicus. So you can go midline if you go quite caudal. So these are our sort of major entry points that we can use. Now, the advantage of this approach is you can see obviously all of the liver. We can see a lot more of the gastrointestinal tract. We can access the bladder if the species has a bladder. The difficulty with this ventral approach is that it's much more difficult to access the dorsal structures without rotation. So very difficult to see the kidneys and small gonads in this kind of orientation. So with regards to patient preparation and draping, typically I warm the OR to 75 degrees for most of my reptile surgeries. It's a standard pre-surgical scrub, aseptic preparation of the coelom. And then the patient's going to be positioned depending on the procedure, whether that be in dorsal recumbency for a ventral or paramedian approach, or in lateral recumbency for a lateral approach. And I prefer these adhesive plastic drapes so the anesthetist can actually see the animal ventilating. For the surgical approach, it's a small skin incision, and typically I'm going to be using a 2.7 telescope in an integrated sheath, or in the 4.8 millimeter, 14.5 French operating sheath. And so my entry incision is about 3 or 4 millimeters. In a smaller lizard, so in the leopard gecko, which is about a 50-gram lizard, you can see there, we're using our integrated or 1.9 system. So that'll be a 1.9 system for the smaller animals. But essentially it's a small skin incision, 3 to 4 millimeters for the 2.7, probably 2 to 3 for the 1.9. And then there's not a lot of blunt dissection that's necessary. I use straight hemostats to bluntly then perforate through the abdominal wall into the coelomic cavity. Once those hemostats are in, then I can replace those hemostats with the sheathed endoscope, or with the obturator in the sheath, remove the obturator, and then insert the telescope and then insufflate. It's important to try and keep a tight seal between the skin and the sheath. So you can see in the iguana on the video here, I'm actually kind of, really kind of trying to get that force through that skin so I don't make the hole too big, because having a nice seal there does make life easier when it comes to maintaining insufflation pressures. So palpate the skin and the muscle. You can feel, in most lizards, you can actually palpate and feel the difference between the muscle layer and the skin layer. Small skin, incision through the skin, and then go in with the obturator and the sheath, or the sheath with the telescope. I tend to prefer going in with a sheath and an obturator, prevent any tissue fluid getting up the shaft of the sheath, I can remove that obturator and then go in with the telescope and then connect up my insufflation line. And typically insufflation pressures are going to be reduced compared to mammals. Still going to be using medical grade CO2, but the pressures will be reduced. And so for most lizards, I'm looking at between 0.2 and 0.5 liters per minute. So much lower than you would be doing for your average dog. And really, I think it's just equivalent to, kilogram body size. I think the important thing is the pressure's a lot lower. If you start to use insufflation pressures approaching 8, 10, 12 millimeters of mercury, like you would routinely for mammals, you're going to find that's going to interfere with venous return. And so we typically only need pressures in the region of 3, 4, or 5 millimeters of mercury to get really nice distension of the coelom. There have been reports of using air, using an aquarium pump and using the finger as a valve. This provides some very crude control. Typically now I only use it in a filled situation if I really can't get compressed gas, but there are concerns regarding air embolism and sepsis. So if you're in a clinical situation in a hospital, we really should be using a dedicated CO2 endoflator and medical grade CO2. Once we enter into the coelomic cavity and we've created some insufflation, then we can do our general evaluation of the structures. And I just want to go through these in turn. Really, the first thing you're going to see in the cranial ventral aspect of the coelom, the largest organ is going to be the liver. Dark red, you're going to recognize it immediately. What may surprise you is that you can actually, in many lizards that have a single coelomic compartment, you'll actually be able to go cranial and see the heart. In many species, there may be no membranous division between the heart and the lungs and the rest of the viscera. So we can go up, we could potentially see the heart, clearly we can see the lungs. And this is where there needs to be some coordination, because you're insufflating the coelom, the anesthesiologist is trying to insufflate the lungs. And so you need to have some cooperation. So if they are currently insufflating lungs and that insufflation decreases when you insufflate the coelom, then they may just have to increase their insufflation end tidal pressures slightly just to get enough expansion of the lung to maintain the animal under anesthesia. As we come into the midpoint of the coelom on the left side, we'll see the stomach. Just behind the stomach, so here's the stomach here. Just behind the stomach, we'll see the spleen in many species, and then the gonad. Reptiles, the males do not have a scrotum between the back legs. Their gonads are intracoelomic. So you can locate those in that sort of dorsal mid-coelomic or dorsal mid to caudal coelomic area. So here's the male, here's the vas, here's the adrenal gland, and as we go further caudal, you'll see that vas and move further caudal to the pelvic inlet. In the iguanid lizard, even though the kidneys are intrapelvic, you can still get a very good visualization of those structures, even in the normal kidney. Obviously, if they're enlarged, they're even more obvious. The intestinal tract is going to be clear in the ventral aspect of the coelom, and if it's a species with a bladder, such as in this iguanid, then you will see a bladder as well. The advantage of reptiles is that they tend not to have diffuse fat around their visceral structures like mammals do. And so fat tends to be sequestered into two localized fat bodies in the caudolateral aspect. So even if you have an animal in very good body condition, that fat body may be significant and large, but it's a single structure, so you can always navigate around it and still see very clearly, kidneys, liver, GI tract, etc. So let's take a little video tour of the iguanid. We've seen the pictures, now let's take a look at the video. So this is on the left side. You can see the lung ventilating there, just coordinating with our anesthesiologist. And you can see the intercostal spaces in the ribs above. As we go up, we can see the heart beating, because in this species, there is no post-pulmonary or post-cardiac membrane. In some species, there are. The TEG use the monitors. It's a bit more complicated. We have paired dorsal aorta coming off the heart and coming caudally. And here you can see the ventral aspect of the vertebra. End of the lung is coming down. Here's the stomach below. Stomach is over in this area here. Here's our stomach. Liver ventrally here, and more intestinal tract. You can see the melanomacrophage pattern on the liver. So here's the stomach. Here's that fat body. This is quite a fat iguana. So big fat body. We can gently move that out of the way, gently using the scope. We can depress, move the fat body. Here's the edge of the stomach. Here's the spleen. And then behind the spleen, we would expect the gonad, which will be just to the right. So here's that spleen again behind the stomach. We're facing dorsally and about mid-coelom. Here's the fat body. We can see there's a vas deferens here. So we have the adrenal gland here. So we can tell it's a male. And we can push this fat body out the way. We can see the gonad lying underneath. So gentle manipulation. This is a single entry process. So we're not doing multiple ports. This is a single port for diagnostic purposes. We can do multiple port endosurgery, but that's a different topic. But here we can see the paired vas deferens coming down. Here's the bladder, and we can see the kidney down there. Here's the kidney. This is a normal, healthy, small kidney, so it's within that pelvic canal. Now on the right side, starting caudally, so here's the right kidney. We're on the opposite side now, the vas deferens, bladder below, and one of the renal vessels. And as we back away further up, we can follow that vas. You can see large fat body here in this iguana. This is quite an obese animal, but we still get nice clear views once we navigate past. Here's the liver. Here's the gallbladder. So reptiles have gallbladders. And here's the liver. And on this side, we can also see the pancreas. So if we move the fat body out the way, we can see the pancreas as it's associated with the duodenum here. So this is probably a 1 kilo iguana. So it's not a tiny lizard by any means, but we can certainly still use the 2.7 system. But that gives you a good overview, I think, of the inside of an iguana as seen through a 2.7 millimeter telescope. So some of the things that we could look for, some of the issues that we have to deal with, there's many issues, but here you can see some granulomas on the surface of this liver. Here's our spleen. Now this is, you can tell this is a female, so immature ovary, quite involuted. Here's the immature oviduct here. So this is an inactive, immature or inactive animal. And certainly we see a lot of reproductive disease in reptiles. And so we're often using the endoscope to either identify gender in monomorphic species as part of a conservation project or breeding project for an endangered species. Or we're using it to identify reproductive disease processes. Here's the kidney. See the renal vasculature here. Trying to get a radiologist to do a biopsy of that kidney is notoriously difficult, but with an endoscope, you can see things so directly. As I mentioned, many lizards have a single compartment, makes it very easy. The tegus and the monitors are a little bit more complicated. They have these postpulmonary septum, which divides their coelom into pleuropericardial and hepatovisceral compartments. There's also a post-hepatic septum in some species that divides it into a pleurohepatopericardial area and a separate visceral space. These membranes can be breached much like avian air sacs. So you can perforate through. Obviously, you've got to be a bit more careful because you're not going from one airspace into another airspace. You're going against tissue. So once you breach through that membrane, you'll then insufflate and you'll push that membrane away so you can navigate through that other compartment. And you don't need to repair. These perforations, they just heal up. You don't need to worry unless you make a huge rent. We don't worry about repairing those on closure. So some of the pathologies we can see, we've identified glomerulonephrosis, tubular nephrosis, bacterial nephritis, abscesses. renal cysts, neoplasia, lots of pathology to be found when you start looking for it. And one of the interesting things is once you start looking with an endoscope and taking biopsies, once you start comparing your biopsy histopathology with your pre-endoscopy clinical pathology, you will start to develop a very healthy distrust of reptile hematology and biochemistry, because the number of times we see nothing on biochemistry and we find major pathology on biopsy, or we see major issues on biochemistry, and yet when we look with an endoscope and take biopsies, there is no real serious disease or damage. And so I think that we have to be very cautious about being too overly reliant on clinical chemistries when dealing with some of these exotic species. We can also see evidence of hepatic issues as well. The one at the top there on the right-hand side, there's a very swollen liver. That was a bacterial hepatitis. The liver bottom left, you can see the very obvious discoloration. That's actually chronic fibrosis in that particular animal. And we can also identify inflammatory conditions, infectious conditions, parasitic cysts, pancreatitis, you name it. Basically, if you start looking, you'll be amazed at what you can pick up in these animals that are otherwise unidentified on either imaging or clinical pathology. Metabolic issues like gout and mineralization actually can look very similar. You see these pale streaks or pale deposits, but again, it's the biopsy which is so important. The biopsy clearly differentiates between soft tissue mineralization and uric acid deposition due to gout. So we can differentiate those at a histologic level, even if they're difficult to differentiate at a more gross level. So let's look at taking some biopsies. Let's start with our old friend, the iguana. So this is, like I say, this is actually about a 500-gram lizard. We're using a 2.7 system in a 14.5 French sheath. We're coming in with 5 French 1.7 millimeter biopsy forceps through the operating channel. Look how we can avoid the renal vein. You can see that renal vein there, but we can avoid it, take our biopsy. We'll get some hemorrhage, obviously, but we can take a nice targeted biopsy. And we've done this in lizards, and we've actually published that these animals cope with these biopsies extremely well. Here's another, this is a different iguana now. Here's an iguana with quite severe hepatic pathology. If you've got diffuse disease like this, then you can take your biopsy from pretty much anywhere. Obviously, if it's focal or multifocal disease, you need to think about taking biopsies specifically from the identifiable lesion, which means that if the lesion is deep and not visible on the surface, that can be more challenging, but that's rarely the case. Usually by the time we're going in, there is something obviously going on, and it's pretty clear. But again, same technique, advance your 1.7 or your 5 French biopsy forceps into the field of view, hold the biopsy, pray to the god of tissue-bound thromboplastin for 3 seconds, and then remove, and you've got your biopsy. And typically, we're not taking one. You know, in a 1 kilo lizard with that 2.7 system, I'd easily be taking 3, 4, sometimes 5 biopsies. I'm usually going with at least 3 for histopath, and then a biopsy or 2 I'll be using for tissue submission for microbiology. So usually, and when you're taking these biopsies, we're not going to be picking them out with a needle. We're going to be basically shaking the biopsies free into saline and then decanting those into a biopsy cassette. Okay, so you saw the 500-gram lizard. Let's go down now. This is an 80-gram chameleon. And so here's the kidney, the gonad testis is here, there's the adrenal. So you're inside now an 80-gram chameleon. You can look at that kidney, you see it's diseased, it's got areas of pallor, it's quite diffuse. We're going to take a biopsy. This is now using the 1.9 system. So that's a 1 millimeter or 3 French biopsy forceps going through the operating channel of an integrated 1.9 millimeter telescope. And the same thing, hold the biopsy for 3 seconds, pray to the god of tissue-bound thromboplastin, take your biopsy. Now, in a small animal like that, I'll probably take 2 biopsies, 1 for histopath and 1 potentially for cultures. But I wouldn't be taking, a large number. Again, here's another chameleon. So this is another, this animal was slightly smaller. I think this was about a 65-gram animal. This is a liver biopsy, again, using the 1.9 system. And under direct visual control that you have with the endoscope, this is actually very practical. I can get vet students and first-year residents able to perform these procedures with just some basic training. This is not overtly complicated surgery by any means. Okay, so I am about 20 slides in, and so I've been told I should be opening things up for questions. So Dr. Chamness, what do you have with regards to questions?
Dr. Divers, I've got a couple of questions here, and I'd like to remind the audience, please, if you have questions, do submit them at the bottom of the screen where it says Q&A. Steve, can you comment on the infection rate in reptiles and whether or not you use pre-op antibiotics?
No, okay, so good question. I don't use pre-op antibiotics. I don't, and the reason for that is because I'm often taking cultures with the samples I'm taking while I'm inside. If I go inside and there is obvious infection and I've taken samples, we then may start intraoperative, intravenous or intraosseous antibiotics, and we will continue that post-op as indicated. But no, I don't do I do not do preoperative antibiotics because often it's the culture which is going to be so important to get at the time.
Right. Next question. Do you do gender identification like we do in birds?
Yes. Yes, we do. We do gender identification. Typically, I'm doing that in those monomorphic species. So mainly it's in either some of the monomorphic lizards, so some of the beaded lizards, Gila monsters, and quite a number of the chelonians, so a lot of the endangered tortoises, turtles, not just endangered species. I've got some breeders who are breeding particular species of tortoise, and because they are very successful, they don't want to release both genders out into the market, and so they want me to do a gender ID so they can only sell excess males. And so it's interesting. So yes, but those gender IDs have been, in fact, it's been an interesting approach for us because I didn't think much of it. I did it to start with for a PhD project. Someone approached me to see if I could identify their tortoises. And I think the last time I checked, we've done about $80,000 worth of endoscopic sexing in chelonians over the last sort of decade or so. So it's been a significant income generator, which I hadn't really thought of. But yeah, we do the gender ID. And typically, sometimes I'll show you some videos actually of that coming up, but we can do that in chelonians down to 10 grams. So the size of just a bit bigger than a quarter. But anyway, we can show that later. Any other questions?
Yes, one more. Obviously, you're using a rigid scope for celioscopy. Do you ever use a flexible scope, either in the coelomic cavity or GI tract or whatnot?
Yeah, so the only time I use a flexible, yes, I use a flexible for a lot of GI work. So to put it in perspective, that rigid telescope will get into the stomach of a lizard up to about 500 to 800 grams. Maybe in some species even up to a kilo. If it's above that, or I need to navigate through into the small intestine, I have to use a flexible scope, in which case I'm either using the 2.5 millimeter or the 2.2 millimeter ureteroscope, or I'm using, if it's a big reptile, then I'll use a gastroscope if I can. And there's I think the 5.9 millimeter is kind of my standard exotic animal gastroscope, because I can use it not just in reptiles, I can use it in big birds, I can use it in ferrets, I can use it in other species as well. With regards to the cloaca going up the other end, I do find a rigid scope is actually more useful than a flexible, because that cloaca is such a complex structure that rigid endoscope gives me more ability to kind of drive around the different parts of the cloaca. And if you've never looked up the cloaca of a reptile with a rigid endoscope and saline infusion, I thoroughly recommend it. You will learn more about the cloaca with that simple endoscopic procedure than you'll ever pick up from two-dimensional textbooks.
Great. All right, Steve, that'll do it for now. We'll continue.
All right, moving on. Okay, and so I'm just focusing here on celioscopy, because if I did all the flexible stuff as well, we'd be looking at sort of 3 hours or so. So I'm just focusing on the rigid celioscopy. And the reason I'm doing that is because I think most people feel comfortable. If there's an orifice, then by all means shove a scope down it. It's where there isn't an orifice and we need to make one. That's where people tend to get more nervous. And so that's why I wanted to focus on, you know, making an incision, an approach to the coelom and going in with a rigid scope. Because I think that's what people are more fearful about trying. Now in snakes, really you need multiple approaches to see all the viscera, right? I can go in one place in a lizard and I can see pretty much an example of all the main organ systems. I can't do that in a snake because of that linear anatomy. So depending on where you're going to be going, if I'm going to go and see the heart, or I want to evaluate the liver or the lung or the gallbladder or the kidney, I'd need to make multiple approaches, which makes rigid endoscopy as a general examination procedure more limited in the snake than the lizards. I still use endoscopy for targeted, like if I know I'm going to take a kidney biopsy, I'll use the endoscope to do a targeted coeliotomy on the kidney to get my biopsy rather than doing a coeliotomy, or a liver biopsy in the same way. So it's targeted if you're doing the snakes. And it's basically a miniature coeliotomy. Typically we go between the second and third lateral rows, and then we go ventromedial to the ribs, or in a bigger snake, you can go through the intercostal space. So you can see these are that kind of incisional approaches, either lateral up the body wall through an intercostal space in say a big boa or python, or we go between, here's the first, here's the second, here's the third. So between the second and third, just maybe a centimeter or 2 centimeters, bluntly dissect. Once you're in the coelom, you can go in with your endoscope and insufflate. Snakes, they're like tubes of muscle. And so often you need to make sure you've got a nice good seal around your scope skin interface, and you're going to need to insufflate to get the distension you'll need to see, but it's certainly possible and practical. As an example, you can see here there's a kidney biopsy, or a kidney you can see on the right hand side. I just want to show you the technique for doing a liver biopsy in a python. This is actually going into the air sac. So you've gone into the snake through the side of the body wall into the caudal air sac, and here you can see that liver through the air sac membrane. So this is kind of akin to what we do in birds. In birds, we go into the air sac, into the respiratory system, and then we access the organs through the respiratory system. And we're doing the same thing in this snake. So I've gone into the air sac because it gives me that nice inflated view so I can see the liver very clearly. I've made a small incision with my 5 French 1.7 millimeter scissors through the operating channel of the 14.5 French sheath here, and my 2.7 scope. Now my 5 French biopsy forceps come in and I can take my biopsy. And the good thing about this, I could take multiple biopsies. I could do multiple incisions, you know, along that length if I wanted to get several biopsies of that liver. So it's just one technique that I found to be quite useful using that air sac system. Okay, let's move on now to the chelonian. I think chelonians are made for endoscopy. You know, they've got that shell, which is such a hindrance to surgery. And I have found now that with the use of an endoscope, I am rarely having to go through the shell. I can achieve so much through a prefemoral soft tissue approach going in front of that back leg. Typically, if we're going to do left or right, it's going to be imaging. If I know I'm going to want to go and see the stomach, I'm going to go on the left side. If I'm going to see the spleen, I'll probably go in on the right side. If there's diagnostic imaging that indicates unilateral pathology, you're going to have to go on that side. If I don't have to make that decision, then as a right-handed surgeon, I find it easier to go into the left prefemoral fossa. So my general approach for me as a right-handed surgeon is going to the left prefemoral fossa. If you're a left-handed surgeon, generally you'll find it easier to go into the right prefemoral fossa, but obviously you've got to watch for any anatomical asymmetry, what your target is and what your diagnostic imaging is telling you. But like I say, if they don't dictate, then surgeon preference can prevail. So we're going through that prefemoral fossa. We're going to tape the pelvic limb caudal to expose that prefemoral fossa. And we use the same technique, whether it's a 20-gram hatchling or it's a 100 kilo or 200 kilo turtle or giant tortoise. We're going to go in front of that pelvic limb and we're going to perforate through the coelomic aponeurosis into the coelomic cavity. So it's going to be a mid-fossa skin incision, again, 3 to 4 millimeters if we're using our 2.7 system. Obviously, if you're going to be using a 5 millimeter scope, because it's like a 50 kilo tortoise, you're going to make a slightly bigger incision. Or if it's a tiny hatchling, you're going to use a 1.9 system, be slightly smaller. But the important thing is once you've made that prefemoral fossa skin incision, blunt dissection using straight hemostats down to the aponeurosis. Once you can feel that aponeurosis, you've engaged on that fibrous aponeurosis, the body wall, you want to make sure that you aim cranial towards the head. Don't go down into the table. You don't want to go down towards the bladder, down towards the GI. Once you've engaged aponeurosis, you want to aim parallel with the table and aim towards the head. Again, we're going to use CO2 insufflation. Although I do use saline as my sort of infusion media, particularly if I'm dealing with very tiny neonates, like you can see on the right-hand side there, or if I'm dealing with small aquatic species, because obviously residual gas doesn't have any influence on a terrestrial tortoise, but residual gas may have some buoyancy concerns in aquatic species. So if you use saline, then you're not going to have those buoyancy issues. Obviously, if you get into big turtles, that becomes prohibitive, and then you'll have to go with CO2 and just try and make sure you get as much of it out as you can. But saline provides some really wonderful visualization when you're inside a 20, 30, 40 gram hatchling. So let's take a look going through the left and right prefemoral approaches. So our endoscope is going to be coming in through that soft tissue window in front of the back leg. Small skin incision, blunt dissection through, perforate into the coelomic cavity, insufflate. Now, you don't need to insufflate. If you let air in, the viscera will sink, but insufflation gives you better visualization. So here's the heart, ventral, close to midline. Here's the liver. We got GI below. So here's our liver. Here's our stomach on the left side. Here's our lung. It's collapsed. If I'm only going in for 5 minutes to take a biopsy, I often don't worry about ventilating. If I'm going to be in there for, more than a few minutes, then we're going to time and ventilate the animal. Typically, ventilation rates are about 1 to 2 times a minute. But as you'll see here, as the lung starts to ventilate, as air is entering the lungs through the anesthetic circuit. So, and here you can see the lung inflating. So again, in this species, we don't have a very well deformed post-pulmonary septum. In some species you will, in some species you won't. But here you can see the lung. Sometimes you can actually go through and look in through one of these windows and look inside the lung itself. So here's our lung. Here's a suspensory ligament here. This is going to be a reproductive tract, a female reproductive tract here. Female reproductive, you see part of the ovary below. There's part of the ovary. Here's the bladder. Here's the large intestine, intestinal tract, large intestine. Here's small intestine, large intestine. And so you get, again, you don't have diffuse fat. You get a very nice clear view. Here's the kidney, right in that chordodorsal area, renal vessel. Try taking a biopsy of this without an endoscope. It's challenging to say the least. But nice clear view. This is actually an adhesion in this one. This is abnormal to have this attachment here. May explain why the animal may be having some reproductive issues. So, and don't be surprised if you see a little bit more free coelomic fluid in reptiles compared to what you might expect in mammals. That's quite normal. Let's take a look inside. This is a red-eared slider, male. And again, here's the liver. You see the melanomacrophages, that black stippling, that's normal. The liver parenchyma is quite pale, so there may be some hepatic lipidosis. We're going under the right lobe of the liver, so it's a right-sided approach. And if you go under the right lobe of the liver and follow the duodenal loop up, you can see the spleen. The spleen is the most difficult thing to find. So if you can't find a spleen, don't beat yourself up, don't cry. It's just one of the most difficult things to find. Everything else is pretty straightforward. Nice dark liver here. And stomach behind. And again, here's the heart we can see beating in that central sort of ventral midline. And so again, we get a nice clear view of these structures, relatively straightforward to be able to go in and biopsy. And really compare this to what you see on a radiograph. You know, you've all seen radiographs of chelonians, and you just see that sort of poor, zero contrast, zero serosal detail. But here you can see the intestinal tract, small intestine, there's the pancreas right there. And so just compare this to what you see on a radiograph and think what you could do diagnostically when you can see this. There's the bladder below at 6 o'clock. And kidney is going to be over to the right. So this is the lung, panning caudal. And as we come caudal, here's the kidney, here's the vas deferens, here's the kidney, renal vasculature, here's the testis, here's the adrenal. So the colonian kidney can be somewhat challenging to locate, particularly if you're dealing with a pigmented species. So if you've got a very pigmented coelomic membrane, it can be difficult to locate unless it's a male. If it's a male, the kidney is intimately associated with the testis. So if you can see the testis and the vas, then even if you can't see the kidney, I know I could make an incision here and get to kidney tissue. In the female with a pigmented membrane, it's more challenging because that mature gonad, the ovary, has now fallen away from that caudolateral attachment. The mesovarium has got large and flaccid, and so the ovary can fall away. Obviously, if the kidney is swollen, then it's going to impinge into the coelom, so you'll see it. And in those species that have a semi-transparent to transparent coelomic membrane, it's a no-brainer that you can easily see that kidney. Okay, so someone asked a question about sex identification. This can certainly be performed prior to the appearance of secondary sexual characteristics. In some species, you might have to wait 3, 4, 5 years or more before you can determine if it's a male or a female. And remember that these animals are temperature-dependent sex determination. So if you're doing a captive breeding program and you get your temperatures wrong, it could be 5 years before you realize you produced all males, which would be a disaster. So a lot of breeders and a lot of conservation projects have been looking at doing these gender IDs or these sex IDs in animals that are, you know, less than 12 months of age. And so here you can see this is a testis, immature, subadult to adult, ovary. This is neonate, immature, juvenile, and adult. So this is possible from about 6 months. You can actually do it a bit earlier than that. If you go too early, obviously they've internalized their yolk sac, and that can be a big hindrance. So you want to be cautious about going too young, even if it's a larger species that could actually accommodate the scope at a young age. And we usually use sterile saline for our sort of infusion, our insufflation. And so here we're using a 1.9 telescope going into, that's probably a 20-gram Asian box turtle. So our 1.9 integrated scope, we've got a syringe of sterile saline. We're literally putting in half a mil or a mil of sterile saline to give us a little bit of lens tissue distance so we can identify what's going on. So Asian box turtle on the left, radiated tortoise on the right. Let's take a look at the video. And so you're inside about a 20-gram Asian box turtle. The liver is pale because it's recently internalized a yolk sac. So there's a lot of fat and lipid going around. Here's the intestinal tract. Here's the lung. So this is the dorsal lung. There's Merkel's diverticulum. That's where the yolk sac was attached. We come in caudally. Here's the immature oviduct. Here is the immature ovary. You can see that clear. They're not always as obvious as this. It depends on species. Some of them are a little bit more challenging. But if we take a very close-up look at this oviduct to show you the visual acuity, you can actually see the erythrocytes coursing through the capillaries with these telescope systems. So it gives you really, really nice images. A couple of pathologies. There's a cyst. Now, this animal would be identified as a female, but this is not an animal that you would want to enter into the breeding pool. There's an obvious abnormality there associated with the oviduct. That animal should not be bred. Here's the male now. You just see about a mil of saline going in. There's our lungs. We're panning caudally. There's the kidney. There's the gonad. So in the Asian box turtle, it's really pretty obvious. And again, you can see the erythrocytes coursing through those capillaries. The Asian, let's look at radiated box turtle now. These can be a bit more challenging. This is actually in air, this is in CO2, but this is a juvenile that you can see there. But they can, if you're dealing with this for the first time, and you've got, usually when you first start doing this, the breeder or the conservation center may have several years. They may have, you know, years 1, 2, and 3 cohorts. Start with the biggest ones and work your way to the smallest ones, because you may get to a point where you cannot tell, where the gonads are not differentiated, and that's your cutoff point. I know for a radiated tortoise, that cutoff point is 100 grams. If they are below 100 grams, I prefer to wait until they exceed that weight, because then I know they can be differentiated. Here's a juvenile male. This is now using saline. So again, we can get those determinations pretty clearly, and it works pretty well. The other things that we identify, if we're not looking at sex identification, it's reproductive pathology. So just want to show you some examples, because I think this is something we deal with very commonly. This is a red-eared slider, so a trichemis. Here you can see the liver there, nice and dark, no real evidence of hepatic lipidosis, large intestine below. There's the stomach. If we pan around to the right, we'll start to see, in this case, there's a abnormality involving the reproductive tract. Here's the lung. Here's this, we've got an adhesion here of the oviduct, and this is the oviduct. We can see part of the ovary. It's a mild change. It's not something that warrants or necessarily necessitates surgery. Now, this is a different animal. Look how pale this liver is. And that's because this animal has been reproductively active, because they try and net excretion of cholesterol and lipid by laying eggs. So we've got big active ovaries. That's one follicle, large reproductive tract. And so you may identify this as a pre-ovulatory follicular stasis. And animals like this often present with metabolic issues because of that hepatic lipidosis if they haven't been permitted to breed. Here's another animal. We start to see if they've had any sort of yolk-associated coelomitis. You'll see these deposits, these yolk deposits over various serosal surfaces. And again, big active ovaries. If you start to see those serosal deposits, it's really a sort of a ticking time bomb, because it means it's already had a coelomitis from the past. It's likely to happen again. But now with the endoscope, that pre-femoral approach, we're actually doing preventative routine ovariectomies in healthy adult female turtles and tortoises. Here's an Aldabra tortoise. And here we've got sort of more granulomatous change. This is a much larger animal. Here's the reproductive tract. And so being able to look around and evaluate, there's fluid, there's more, see the increased fluid. Again, if it's clear, that's one thing. Once it starts to become cloudy, and you do see increased fluid like this in normal reproductive activity, once you start to see an accumulation, and particularly once it starts to go cloudy, then that is certainly a red flag. And so in this case, here's a box turtle. This fluid, now you can see how flocculent this is. There's an active coelomitis going on. And this animal, if this is a septic coelomitis, i.e. bacterial involvement, this is a surgical emergency. This animal needs to be taken into the operating room as a matter of urgency. So anyway, just wanted to show you some of those. The time is ticking away, so I want to get through and show you a few things. Colonian biopsies. Again, similar to taking biopsies in the lizards, your biopsy faucets come down into the middle of the field of view. We can see what we're biopsying. We often take it from the edge of the liver, unless there's a focal or multifocal pathology and we have to take it specifically from the site. You can lift up, make sure you haven't caught the stomach or the serosa of the intestinal tract, take your biopsy. Kidney is more challenging. See that renal vessel there? Always makes radiologists nervous about going in with an ultrasound guided, but with a pair of our 5 French scissors, we can use that fixed blade like a knife. We can go along the edge of the kidney and the coelomic wall, and we make a small nick, and then we can pick that up with the point of our scissors and cut and just sort of tear it and drag it so we can get exposure like we can see there. So having exposed that retrocoelomic kidney, we can now go in with our 5 French biopsy forceps. Again, this is single entry for the vast majority of chelonians. If you've got a really big animal, you're going to be probably using 2 instruments and triangulate. But now we can open up, take our biopsy from that kidney. Again, hold 3 seconds, pray to the God of tissue-bound thromboplastin, take that biopsy, and we've avoided those major blood vessels in very close proximity. So these biopsies are fragile and small. I shake them off into a ml or 2 of saline, into a sterile red top, then decant those into a biopsy cassette and put those in formalin. Or if I'm submitting for microbiology, my lab's just down the corridor, so I'll leave my biopsies in saline and send them to the lab for microbiology. If you're mailing them, contact the lab. They probably want you to put that biopsy in transport medium. All right, questions again?
Okay, Steve, can a biopsy of infected tissues increase the risk for sepsis?
I think that's a potential risk, but in my experience, the risk of failing to make a definitive diagnosis carries a far greater risk. And so typically I find if I can go in and take a biopsy, and a lot of these times, if it's diffuse, you're not going to, if you have something encapsulated, something that you think may leak everywhere, then before you take a biopsy, you can go in with the 3 French remote injection needle through your operating sheath and then put your needle into a structure and aspirate. And if you aspirate fluid, then I wouldn't take a biopsy. I would submit that fluid for culture and cytology. And usually they're fairly solid, and then you can take a biopsy instead. But to answer the question, it's a theoretical risk, but in my experience, failing to make a definitive diagnosis is a far, far greater risk. By the time the number of times I've gone into a reptile and gone, why the hell why didn't we do this 3 months ago? Why wasn't this referred earlier? The number of times in 25 years I've gone, oh, probably shouldn't have gone in and scoped that animal. I can't think of them. I just can't think of them.
Mm-hmm. Okay, if you go into the lung, does it heal up and close on its own, or would you need to close it yourself?
No, you do need to close the lung. So I'm going to show you an example of that, actually. So let me go on, because I know I'm running out of time and I want to show you. So as you were talking about going into the lung, here's an example. This is this transcutaneous approach. We talked about going in this site to actually get to the liver, but this is a great way of doing a lower respiratory tract evaluation in a snake. And so just look at the detail, the pulmonary detail. You're looking at the faviolar tissue of the lung of a ball python here. And we've done this and we've taken biopsies and gone back in a year later and they heal up great. But being able to take biopsies, you can go all the way up to the opening of the primary bronchus and the trachea. This is a site, this sort of anterior area here where you can often get inspissated pus accumulate. But this is a great way of going in and taking samples. But when you come out of that lung, in the snake, it's not too much of a problem. We still try and close the lung, but there's such a tube of muscle that you don't have a problem. The animals where you may have more of a problem is in the chelonians, where you want to make sure you close that prefemoral site. So let me show you the turtles. So here's an example of going inside a turtle. So you go in, it's a larger incision, but you basically ventilate the animal so you can see the lung moving. You tag the lung, you put 2 stay sutures, you elevate it up to your prefemoral incision, stab incision through one of those avascular windows, go in with your endoscope, and that's what you basically are seeing here. Here's the difference, by the way, between a standard camera and a high definition camera, right? But you can now navigate through this lung, and again, compare this to what you see on a radiograph. Compare this to what you see even on a CT, right? And more importantly, if I see something abnormal, I can biopsy it. I mean, there's nothing worse than seeing something on a radiograph or a CT and going, whoa, that looks cool. I just wish I knew what it was. Well, with an endoscope, you can, right? You go and you can take a biopsy. But when you back out, you know, those 2 stay sutures that you had holding the lung, well, you want to do a circumferential suture around that hole and tie it off, because you don't want air entering into the coelomic cavity, which could happen, I think, more in a chelonian or in a lizard, less of a problem in a snake. But I just wanted to throw those in. And I know I'm running out of time because I've been told I have to finish by 9 o'clock, right? So let me keep going.
You won't turn into a pumpkin if it's 9:01. Yeah, go ahead. Continue.
All right. So once you finish your coelomic evaluation, it's evacuate your gas or your saline. You can apply gentle suction. You can allow passive drainage. Single suture typically to close the skin. We don't worry about closing the hole that we made to get in. You do need to close the lung, particularly in colonians. I haven't closed the lung routinely in snakes and I haven't had a problem. I do routinely close the lung in lizards and in colonians. And if it's an aquatic species, I'll put some tissue glue over that suture so it's going to be watertight. Just want to show you an example of endoscope assisted surgery. Here's a red-eared slider with retained eggs. If you look at its biochemistry values there, if you just looked at that biochemistry, you've got maybe a moderate leukocytosis. You've got phosphorus is decreased, calcium is normal, chloride is decreased, sodium is decreased. So biochemistry, moderate leukocytosis. Here's the CT, right? Radiographs show you these eggs, which we can see also on our CT. But what you can't see on the radiographs, but you can on the CT, is the rest of the coelom is basically just predominated by these large ovaries. So this animal's reproductive tract is diseased, abnormal, and occupying most of its coelom. So here's an example of how we can go in and use the endoscope, not just as a diagnostic, but as a surgical aid. And here's an example of how I don't have to go through the shell. You can see this animal's problem. We've got coelomitis. You've got this serosal debris from the egg coelomitis. And this animal actually had a bacterial infection as well. So there was a bacterial component, a septic coelomitis, big ovary on each side. There's the bladder, here's the liver. And we could aspirate from that bladder and do a cystocentesis to close it down. But just to kind of give you, we can then go in with the scope, identify the oviduct, exteriorize the oviduct or the ovary. In this case, the ovaries were the closest thing. So we take out the ovaries first, you exteriorize the ovary, and then you clamping the blood vessels using vascular clips, or if you want suture, vascular clips are easier. Then go back in, grasp the salpinx, exteriorize that. And here you can see the disease process. This thing is just grossly abnormal. And it was ruptured before we even got in. We've caused some more of that bleeding with our manipulation. But I just want to show you the amount of material and how you can take this out using endoscope guidance. And a lot of this exudate, it comes out as a big mass of, it's an inspissated, horrible mass of tissue. And so these cases now are soft tissue. We can go in with an endoscope, resolve them. They heal up within 6 to 8 weeks. You haven't gone through the shell. You can go back in and evaluate them endoscopically. And so it's really transitioned. It's really changed our approach to internal surgery, coelomic surgery in many of these colonians. And then it's a soft tissue closure. All right, that's 9 o'clock. So I'm not going to talk about this, but basically there's lots of publications out there now with chapters on endoscopy that's available. There's a lot of material that's out there. There's that QR code where you can get a copy of the PowerPoint. Basically, to summarize, endoscopy, I think, offers unparalleled visualization of internal structures and visualizations that you can actually do something with. You can take a sample, a biopsy. 2.7 is most appropriate for most species, but the 1.9 is preferred for animals under about 150 grams. Insufflation is critical in the lizards and snakes. Certainly, it's still helpful in the colonians, and it facilitates diagnosis through biopsy. You get a biopsy, if you can demonstrate a histological pathological change, and you can demonstrate the etiologic agent, you've got a diagnosis. It's going to dictate treatment. And then some shameful advertising to close, while Christopher maybe provides some more questions.
Okay, Steve, just a couple of questions. One, how did you safely anesthetize the Gila lizard given their venom?
Okay, well, that's a whole story, and it's actually a comical one, and I really can't get into it. But we were using a ketamine alpha-2 combination for those animals, and the reason it's funny is because I'll take 30 seconds to tell the story. So basically, I told everybody, I'm going to grab the heloderms while they're conscious. My resident's going to inject the heloderm with the ketamine alpha-2. We used medetomidine, and I think with hydromorphone as well. And then I'm going to put it into its induction area, and we'll leave it until it's quiet, and then we'll take it out. I said, these guys are pretty slow. Their venom, they have to really grab you and chew on you. You have to be stupid to get bitten by a heloderm. Anyway, I was grabbing the heloderm, and then the resident was taping the mouth up. And so she taped the mouth up, and I said, right, is it secure? She said, yes, it's secure. I said, you sure it's secure? She said, it's absolutely secure. And then the lizard kind of just jerked, and I pulled my hand away, and my hand started bleeding, and my technician thought I had been bitten. I just kind of scraped it against its tooth. It didn't actually kind of bite me. What was interesting is the technician was thinking about rushing out the door to get me, the car to take me to the local ER. And all I can remember really is the student behind me going, but Dr. Divers, did you say you had to be stupid to get bitten by a heloderm? But yeah, so that was an injectable. Now that was because we were doing large numbers. If I was doing clinical cases, an individual, I would still prefer the injectable induction, intubation, and onto gas, although we're doing a lot more CRIs of alfaxone and propofol. To be fair, I'm moving away from gas anesthesia in reptiles and moving more towards CRIs, constant rate infusions of alfaxolone and propofol, and it seems to work, at least so far, so much better.
Wonderful. One final question. Complications. Any general comments about complications with laparoscopy or celioscopy in reptiles?
I think the biggest complication I see is people waiting too long. You wait and people try this treatment, they try that treatment, and the animal is chronically deteriorating and getting worse. And then by the time I get to go in with an endoscope, I'm presented with an animal that's 90% dead. Would have been nice if it was presented earlier in the course of disease. So I guess the first complication isn't so much a complication, it's don't make life difficult for yourself. Get in early in these cases. Do not delay. Don't put them on a 4-week course of Baytril. Don't, mess around. If you need to do those investigations pretty quickly, because often they've been hiding symptoms of disease, or it hasn't been noticed for days or even weeks or sometimes months. Complications that I see with celioscopy, probably, let me think. Nothing's really coming to mind. I guess the important thing, I think it's important to get some practical training. I think it can be, and if you can't get to a course, then one thing that I did when I was in practice is I would offer endoscopic necropsies. So if I had an animal that died for whatever reason, or for whatever it was going on, I would say to the client, because often they would be resistant to do a necropsy because they wanted their animal back for burial, I would offer them an endoscopic necropsy. So I got to practice in a fresh cadaver with zero liability. It's already dead, divers. You can't make it any worse. And yet it gave me a lot of practice at popping in, getting to kind of know the pressure I needed to get through that muscle, being able to access. So that's, I think, is important. And there are some courses available. Ours is here at UGA. I think there may be courses coming up in Asia as well. So I think there's courses around for exotics. Probably the other biggest complication is in the colonians. And probably involving the bladder, either the bladder being too big and you hit it, or you puncture it, and then you've got to flush out and ligate that bladder, close that bladder back up. So try and make every effort to bathe that animal to encourage urination, digital stimulation, try and get it to urinate. And when you first go in, put them in lateral recumbency so the bladder sinks down to the lowest point. So I think probably the bladder's the biggest concern I have, probably in the colonians. Lizards and snakes, I'm not too worried.
Beautiful. All right, we're going to leave it at that. Thank you, Steve, for another information-packed presentation. We appreciate your willingness to contribute to endoscopytalks.com twice. And once again, I'd like to thank all of you in the audience for joining us. In the meantime, we wish you all the best of health. Thank you.